Lonnie Stonich, the Executive Director of FAN. We're a nonprofit that presents programming exploring human development across the lifespan. I'm honored to welcome you to tonight's conversation between Dr. Anupam Bapu Jena and Robert Kolker. Thanks for joining us for the first event of our 2023-24 season. FAN's YouTube channel has an archive of nearly 300 videos of past events, so be sure to subscribe to the channel to get updates when new recordings are posted. And now for some introductions. Anupam Bapu Jena is the Joseph P. Newhouse Professor of Healthcare Policy at Harvard Medical School and a physician in the Department of Medicine at Mass General. He is also a faculty research fellow at the National Bureau of Economic Research. As an economist and physician, Dr. Jena's research involves several areas of health economics and policy, including the use of natural experiments in healthcare, the economics of physician behavior and the physician workforce, medical malpractice, the economics of healthcare productivity, and the economics of medical innovation. Dr. Jena graduated Phi Beta Kappa from the Massachusetts Institute of Technology and he received his MD and Ph.D. in economics from the University of Chicago, and he completed his residency in internal medicine at Mass General. He is also the host of the Freakonomics MD podcast, which explores the hidden side of healthcare. We are so pleased to welcome Bob Kolker back to FAN. We hosted Bob in 2021 for an event supporting his book, Hidden Valley Road. He was in conversation with fan favorite Andrew Solomon. Hidden Valley Road, an instant #1 New York Times bestseller and selection of Oprah's book club that was named a top 10 book of the year by the New York Times, the Washington Post, the Wall Street Journal, and Slate, and one of President Barack Obama's favorite books of 2020. His previous work includes Lost Girls, also a New York Times bestseller and New York Times notable book, and one of Slate's best nonfiction books of the quarter century. He is a National Magazine Award finalist whose journalism has appeared in the New York Times Magazine, Wired, O, the Oprah Magazine, the Marshall Project, Bloomberg Businessweek, and New York Magazine. And now let's welcome Bapu Jena and Bob Kolker to FAN.
Hello, hi Bapu.
By the way, that was a generous introduction of us both.
Yeah, seriously.
Thank you, and thank you, Lonnie.
Yeah, let's start that way for sure. Thank you, Lonnie, and thank you, FAN. Welcome to everyone to a new season for FAN. I was privileged to be interviewed in a FAN event 3 years ago when my book came out, and that was during the shutdown. So I did nothing but Zooms, basically morning, noon, and night for book promotion for months and months and months, which gave me, I guess, what an economist or a researcher would call a tremendous sample size to choose from. And certainly the FAN event was a cut above the rest. Lonnie is wonderful. FAN it has meaningful talks that are also super smart. And so I was thrilled to be invited to talk to you, Bapu, about your terrific book. It passed by very quickly in your bio, but it's in the thing that really sticks out to me is that you are an economist and a physician, which seems like a rather unusual blend. Certainly not a lot of people are really both. Your book is special in that way as well, because it is filled with research and experiments and surprising findings on every page that start out delightful and then work their way up to something more profound about the way human nature works, the way society is functioning, and the way healthcare is changing. And so I'd like to talk, about all of it with you tonight. But a little more praise for the book before I begin, just in case people missed it. The Wall Street Journal said that Bapu and his co-author, Dr. Christopher Worsham, are the freakonomicists of the medical realm. And I think what they mean by that isn't that you find fun, counterintuitive, more nuggets to share with the public. It's that you are experts in what are called natural experiments. And I thought that would be a good way to start, to ask you how your training and background as an economist and a physician brought you to the point where you wanted to write a book to help the public understand natural experiments.
Wow. So first of all, I'm an economist and a physician. It's pretty uncommon. I don't know if that's a good thing or a bad thing. It's, but so let me say the following. Anybody who has taken a medication, we're talking about natural experiments here. I think probably the best way that I think about it is to think about something that's really familiar to us. So any of us that have taken a medication that our doctor or nurse practitioner has prescribed to us, typically the data that supports the use of that medication comes from a randomized trial where you take a bunch of people who have a medical condition, let's say diabetes, and then you randomize half of them to get the medication and half of them to get either a different medication or sometimes a placebo. And then you study the effects on outcomes that you care about. And the reason we do this randomization is because it holds everything constant between these two groups of people. The contrast to that is what we sometimes see a lot of in the news and in medical studies, where we simply look at people in the real world who use a treatment and those who don't. And the challenge is in the real world, people choose to use treatments. And so you can't infer anything about whether or not that treatment is causing them to have a good outcome or a bad outcome based on the treatment itself, because there's a lot of other factors that might not be the same between people who choose to take a certain medication and those who don't. And that's where these natural experiments come in. What a natural experiment is, it's nature's way of randomizing us by chance to two different paths of care. It could be the type of surgeon you see. It could be the type of medication you take. It could be how long it takes you to get to the hospital. For example, you would never randomize people with chest pain to say, all right, half of you wait half an hour to go to the hospital, the other of you go there immediately, so we can study the effect of delays in care. But nonetheless, it is important for us to know how quickly we need to act in medical circumstances. So these natural experiments are quite powerful in that way.
The most elegant example of a natural experiment in your book, and the one that really helped me understand what exactly it was, to me anyway, it was cholera, where, the people drinking out of that well are getting cholera and nobody else is. And so you understand it's not in the air. It's not an infection. It's not based on what anybody does for a living. You have, as you said, a fully randomized population. The only difference is the people drinking out of that well are getting it. And that helps you understand. And to me, that helped explain what they were. But the experiments in your book to try to use, the natural experiment way to try to find out something, they are not as quick as that. They take a lot of devising, a lot of ingenuity to come up with the exact right way to analyze what's happening in our world to make sure that your data is clean, that it's not fouled up. And I thought I'd ask you, this sounds like it's the ball game for you. If you're going to be in this line of work, devising the experiment is the real challenge. What drew you to that kind of work, and what do you get out of it, and what do you can you describe the challenge to us as you're in the middle of it?
Yeah, it's a confluence of factors. As Lonnie mentioned, I spent a lot of time in Chicago at the University of Chicago. I was actually born in Chicago and moved to Virginia, where I grew up, and then moved back for medical school and did my PhD in economics there. And there's a few people who were there at the Department of Economics who were pretty influential in helping me think about the world, at least as an economist. And one of those people was Steve Levitt, who was one of the co-authors of Freakonomics. And what I loved about his work, and what a lot of people loved about and continue to love about his work, it was just so creative. And it approached the way we make decisions in life in just a novel way, a way that people hadn't been thinking about before. And it struck me that in medicine, the same things that he was thinking about apply, but in some respect, they apply on a much higher stakes. Like, for example, when we talk about medical decisions, they're oftentimes life or death decisions. Mortality is an endpoint that everybody cares about, and it's very meaningful to people. And sometimes it's hard to figure out what it is that's going to help people do well after a surgery or after a heart attack or if they have the flu. And we rely on medical knowledge that's generated from clinical trials oftentimes, but sometimes that's inadequate. And we got to figure out better ways to kind of teach us what works and what doesn't work in healthcare. And so the tools, the thinking of Steve Levitt and others like him sort of attracted me to that kind of line of work, and blending with medicine felt like a really natural fit because, again, the stakes are high. And just think about all of the uncertainty that is there. When you go see a doctor with a medical problem, it's not like going to buy a TV or a microwave. There you've got a lot of experience with what kind of TV you like, what kind of microwave you like. But you don't have much experience when it's a new diagnosis of cancer or heart failure. And there you're kind of putting your life in someone else's hands. And that, that uncovers a host of other really interesting and also challenging problems to think about.
Um, I want to put a pin in what you said about doctors, because I have a whole slew of questions to ask about them and how we judge them and measure them and the things that might be surprising about them. But before we do, there are things about our world around us and public health that really astonished me in this book, and I thought I'd ask you about some of them. The first is, I believe it leads the book. It has to do with how whether or not a kid might get the flu has something to do with what time of year they're born. Something that comes completely out of left field, and yet you came up with or found the reason why. Can you talk a little bit about that?
Yeah, sure. And by the way, it's that time of year, or it's about to be that time of year. I'm going to answer that question. And then Lonnie, before we jumped on, had a interesting observation that I'll expand on if you allow me as well. So let me just share some personal information. We've got two kids, a 6-year-old and a 9-year-old. And when our 6-year-old is our son, when he turned, I think it was like 3 or so, I took him for his annual checkup. Most kids, when they get their annual checkup around their birthday. And so he has an August birthday, middle of August. And so I took him to his 3-year checkup to his pediatrician around the middle of August. And everything went well. And as I'm walking out of the doctor's office, the nurse says to me, sort of in passing, come back in a few weeks, we'll have the flu shot ready. And the first thing that I thought, I was like, wow, had my son been born just 2 or 3 weeks later, they would have given him the flu shot in the office that day. And instead, what I had to do was figure out a way to bring him back to the pediatrician's office. And it turns out it wasn't easy, because as soon as the office visits opened up for flu shots in his doctor's office, the appointments were all booked up within literally, a day or so. And so I'm calling around CVS and Walgreens, and nobody's vaccinating a 3-year-old. And ultimately, I actually was able to get him into the office and took about a half day off of work to drive there, get him vaccinated, and take him home. And of course, it was important to me to do that, so I was willing to do it. But you can see where this is going. That's a barrier, and it's sort of totally random when he happened to be born. And so we looked at that in a study, and we wrote about it in the book. And what we found was that kids with summer birthdays, because they tend to go to their annual checkups in the summer around their birthday, they are less likely to get the flu shot, quite a bit less likely to get the flu shot, because it's not available in the office yet. And it becomes available late August, early September. And so the kids with summer birthdays are less likely to get the flu shot, and they're more likely to get the flu. And the other thing that's interesting and probably predictable is that their family members are also more likely to get the flu. So if grandma or grandpa lives at home, they're also more likely to get the flu. So again, it's an interesting finding, I think it was kind of a curious link or curious relationship, but it does have implications when we think about how to design policies to make sure that kids get vaccinated. You got to lower the barriers for them to do that.
But the nuts and bolts behind a study like that, if you're measuring grandma and grandpa flu rates, does that mean that you're looking at instances of the flu with an elderly population and then inquiring to see if those people have young people in their lives who are around them? And how, just being able to filter out the right people for a study like that feels very painstaking.
Yeah, and it's difficult, and the challenge is, and maybe this is a good way to bring up this question that Lonnie asked me. We were talking, and I'll just recant a story. A few years ago, you were mentioning Zooms. So we had a Zoom faculty meeting, and my chairwoman at Harvard said to me what I've been up to, asked me what I've been up to. And I told her, I was like, I just got back from CVS last night, and my arm is sore because I got the flu shot. And she said, well, why'd you get the flu shot? I was like, well, what do you mean? My wife told me to go get some Doritos from CVS. I saw a sign for the flu shot. I got the flu shot. And she said, no, 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 but Bapu, it's September. Why would you get it so early? Aren't you worried about your immunity waning? And I said, Barbara, I had never thought about that. And so she asked really an insightful question. If you get vaccinated against the flu in September, maybe your immunity wanes, but something like November or December might be too late. And the question might then be is, what's the optimal time to get the flu shot? And you could solve that in two ways. You could say, all right, let's do a randomized trial where we randomize people to get the shot in August, September, October, November, December, etc. And then you study the rates of flu. That would be one way to do it.
Yeah, but I wouldn't want to be in that study.
You wouldn't want to be in that.
Want to
Yeah,
be
exactly.
in the losing group.
You wouldn't want to. Then there's a wrong way to do it, which is say, let's just look at people who get the shot in September or who get it in December and study their flu rates. The problem there is that people who choose to get the vaccine in either September or December are different. And so you can't infer anything about the effect of getting it early versus late on your likelihood of getting the flu.
That's
And
funny
then
because
the
I would have chosen to do that study. I would have been like, okay, great, that'll be fine.
Well, no, not after we chat. After we chat, you'll do it differently. So it comes back down to the birthdays, right? So the birthdays are essentially a way that kids get randomized. I use that in air quotes because there's no researcher doing it, but by chance, by nature, if you got an August birthday and you get vaccinated, you'll tend to get vaccinated more often in August. Whereas if you got a December birthday, you might be more likely to get vaccinated in December. And so what you can do is don't look at the actual time that kids get the shot, because that's a choice, but look at their birth month. And the kids with these October birth months is what we show, they are the least likely to get the flu. And guess what? They're most likely to get their shot in October. So that would be a way to say, all right, the optimal time to get a flu shot if you're a kid is October. And we know that because something that's totally random, like your birth month, predicts when you're likely to get the shot because of when you happen to go for your checkup. This
is good news for me because with our kids, we'd always end up happening in October because we never got our act together.
Yeah, you're a good parenting.
Exactly, it's good parenting. But but it's a good, interesting example because you found this very elegant way to measure something relatively important. And you did there's another one with air pollution that involves Easy Pass.
Yeah, the air pollution one is interesting. When you were talking about the cholera outbreak in London and how people figured out that it was coming from the water, I was thinking about pollution. And so there is a big question about what is the effect of pollution on our health. Now, most of us might think, all right, bad air quality is not good for your health. But it matters what the magnitude of that effect is. Is it a small effect? Is it an enormous effect? Is there somewhere in between? You want to know the magnitude because it's important then to design policy around that. Because if it's a small effect, maybe we can treat air pollution, air quality a little bit differently than if we know it's a big effect. So how do you answer that question? Well, you cannot look at areas that are heavily polluted and areas that are less polluted and look at outcomes of people in those areas, because the areas that are very polluted are different than the ones that are not. And of course, you can't randomize areas to get more pollution or less pollution. So how do you solve this? The economist, she's a Princeton economist, Janet Curry, and her colleague Reed Walker had this really elegant study using Easy Pass. And basically what they showed is that when an area introduces Easy Pass, there's an improvement in air quality locally, right around that area. And the reason why is because before Easy Pass, what were cars doing? They're driving on the highway and they're just kind of sitting there in front of the toll booth, letting exhaust go into the air. But when Easy Pass comes into effect, those cars just go zipping right through that area. There's not this local buildup of pollutants. And if you look at things like infant health outcomes in areas where Easy Pass is introduced versus areas where it's not, and you look before and after the introduction of Easy Pass, you find that that introduction leads to an improvement in infant health outcomes. And the idea is it's because pollution is lower. They can quantify the magnitude of that effect.
It's premature births that they were measuring, right? The number of premature births, which is a stunning thing. Because again, if someone asks me, can you just measure how much better people are feeling now that the Easy Pass is gone? There are a million ways to do that, and most of them are bad. But premature birth seems like a pretty clean way of figuring out, a difference.
That's exactly right.
Very
Yeah.
dramatic as well, and meaningful. So I think these are. I wanted to start with stuff like this just to get us all used to the idea of natural experiments and how they work. And then there are certain terms that keep coming up in your book that are fun and also very helpful that I thought I'd do a quick lightning round now with you just to ask you about them. Explain to us what the Hawthorne effect is.
Okay, so the Hawthorne effect is this idea that when people are being monitored, their behavior changes. Now, that's not surprising. If you're a child and your parents are watching over you as you're doing your homework, you're more likely to be doing your homework than daydreaming. Now, that is a fundamental idea in the social sciences, because in the social sciences, we often get information about people's behaviors, how they think, how they act, by surveying them. But if they know that they're being surveyed, might they respond or behave differently than they otherwise would if you're sort of more kind of in a cloaked way trying to assess their behavior. Now, what does this have to do with medicine? I'll tell you a story about my wife. My wife is a physician here in Boston. She's a radiologist. And a few years ago, it was a Monday morning, and she's waking up and she looks at her phone. She gets an email from her hospital, and it says that something called the Joint Commission is visiting the hospital that day. The Joint Commission is this body that regulates American hospitals. It visits them every few years. It's responsible for making sure that they're doing everything they're supposed to do in terms of quality and safety, infection control, all of those sorts of things. But she looks at me, she says, "Bapu, the Joint Commission's coming. We're going to be running around like chickens with our heads cut off." And I was like, that was sort of an interesting observation. So I said, well, we should get data on all of these visits to US hospitals and then look at what happens during the dates of these visits, because maybe, I thought, patients would do worse because doctors, nurses, therapists, everybody would be, doing something in a way that they normally don't do it, right? And that might be distracting. It might lead to worse outcomes. And so we look at the data, and Bob, what we see is the opposite. What we see actually is that during the dates of these visits by this inspection agency, I'll call it, mortality falls. So much so that if these visits happened all the time, there'd be 30 to 50,000 fewer deaths per year in the US, in the Medicare population. So we are finding pretty big effects, and we think it's because people's behavior, doctors, nurses, all the medical providers, their behavior changes in the setting of being monitored. So that's an example of the Hawthorne effect.
So you're saying when evaluations happen, the death rate goes down or up?
It goes down. It goes down because people are sort of dotting their I's and crossing their T's. They're a little bit more on their game.
But then you have a separate finding where there's a doctor convention and the doctors aren't there. Suddenly everything goes better.
Yeah, that's different. Yeah, that's different. So that is based on something I experienced when I was in training. I happened to be working as a resident in the hospital. I think it was around the time of one of these major cardiology meetings, like the American Heart Association or American College of Cardiology. And these meetings happen every year. They're huge. In fact, Chicago hosts a bunch of these major medical meetings. And I was curious what would happen to people who have a heart attack or whose heart stops. We call that cardiac arrest. What happens if that happens to occur during the dates of one of these meetings when all the cardiologists or some of the cardiologists are out of town? They're at the meeting. They're not at the hospital where they normally work. And again, Bob, I thought that we would see worse outcomes. I thought people would do worse because the staffing would be lower, or the quality of the physicians who remain behind might be worse. And we look at the data, and by the way, this is a good natural experiment. Why? Because people who have a heart attack, first of all, they may not have heard of the American College of Cardiology, much less know when the American College of Cardiology is meeting. And so they're not timing their heart attacks to occur or not occur during the dates of these meetings. It's totally random with respect to when their chest pain and their heart attack occurs. And so what we see is that people do better. their mortality rate goes down if they by chance are hospitalized during the dates of those meetings.
That
And
is
the other
amazing.
data point, it's amazing. It's crazy. I was
It's like a bad
surprised.
joke. It's like, I went to the doctor during the cardiology convention and I did better than I did.
Yeah.
So we're talking about two separate experiments here, and I went too quickly through the first one. So let's unpack it, because they feel like contradictory findings, but they both are really compelling. So you have in the first experiment that we were discussing, where you found that when people at hospitals have somebody looking over their shoulder, outcomes are better. And that seems nice until you think about all the times when no one's looking over their shoulder and you see the tens of thousands of mortalities nationwide that might happen. These adverse, unpredicted health events were preventable deaths that could have happened. And it makes you wonder, how can we tweak the system so that doctors and healthcare professionals can do that well all the time and not just wait for somebody to be looking over their shoulder? Do you have thoughts on that, on how to?
Yeah, it's a difficult question. I think first, what you need to do is figure out what exactly is being done differently. And I think that's sort of more of like an anthropologic analysis. You have people who will just be in the hospital observing how behavior of all the medical providers actually changes, because then it leads to a somewhat more difficult question is, all right, it's obviously going to be too much for the hospitals to have the Joint Commission there all year round. That would be very, very stressful, right? So that's not the solution. But the question is, are there certain things that might increase focus and attention in a way that's manageable, right? In medicine, as in anything that we do in life, there's trade-offs, right? We could drive down mortality at immense cost. And we try to make a trade-off in society about how do we sort of get the most with what we have. And I think that there are probably ways that we could improve focus and attention at work. We already see some of those things happening in the operating room, for example, to reduce surgical errors that might happen. But think about all the things that happen in the hospital. There's so many distractions. Doctors or nurses are getting paged. They're getting alerts popping up in the electronic health record. They're kind of putting out emergencies. So there's all of these areas where distractions can occur. You might forget something. You might have been thinking about a diagnosis, thinking about sending a lab on a patient, and then you forget to do so. So I think that there is some real work to be done to figure out what we can do differently in those domains, because I would characterize them the way that you did. These are preventable deaths.
It's amazing. And what's most amazing to me is that you found a way to measure distraction of healthcare workers by measuring a lack of distraction, by looking at a moment when they are more focused, when somebody is evaluating them or looking over their shoulder, where a nurse or a doctor would be less inclined to look at their phone every 30 seconds than
Exactly. Yeah. That's a good way to put it.
It's amazing. And then when they're out of the hospital altogether, suddenly things go better than usual. And this speaks to another potentially troubling reality. You dug into this question, I believe, in your work. Why during the cardiologist convention do people with cardiology problems have less of a mortality rate once they come out? Why is this?
So I withheld one important piece of data that might lead us down the right path. So it is the following, is that also during the dates of those meetings, we see rates of certain procedures, certain interventions that sometimes offer benefits, a lot of times offer benefits, but always entail some risk. We see rates of those procedures fall by a good amount during the dates of those meetings. And then the question is, well, how is it possible that when you do less of something that we think is good, like a medical procedure, that people end up doing better? Because what we would think is that if we do less of something like a medical procedure that is known to be or thought to be helpful, if we do less of it, people should do worse. And the way I would describe that is probably just by giving you an example of two people. So the first is a guy, let's say, who's a construction worker. He doesn't have any medical problems that he knows about, and he develops chest pain when he's working on the construction site. And he gets taken to, let's say, Northwestern Hospital in Chicago, and they diagnose him with a heart attack. They do an EKG, put some leads on his chest, measure the electrical activity. He has a heart attack, and he gets a stent, and he leaves the hospital in 2 days and lives a long life. That's the first person. And then the second one is a 9-year-old woman who lives in a nursing home. And one day she develops chest pain, the exact same chest pain as this first guy. She gets taken to the same emergency department. She also gets an EKG. It looks the same. She's also having a heart attack, and she receives a stent, but then she passes away from complications of that procedure. It's something that is not surprising to many people who would hear that story, this sort of hypothetical. And in medicine, you know, we want to believe that we're operating in an area that's black and white, like we always do this and we never do this. In reality, there's always these areas where there's gray. So for example, for the woman, we intervened on her thinking that it was sort of a black and white decision. She has a chest pain, she has chest pain, she has a heart attack, something is blocking the arteries of her heart. We open up that blockage, she does better. That's our hope. We behave like that. But it's sometimes the case that that can cause more harm than benefit. And I think what this study illustrated for me, at least, is that in medicine, most of the time, I think, or a lot of the time, more is more. You do more medical care, it'll tend to help you. But it's sometimes the case that less medical care could be more. And I think that's what the study illustrates.
This idea of overuse of procedures, of doctors sometimes doing too much, it speaks to, I think, the fears that a lot of people have that the last thing you want to do is go to the hospital. That's where bad things happen. You'll just run into trouble there. But you don't just stop there. You're looking at doctor behavior and the psychology behind the impulse to do something. And you have lots to say about that in the book. In fact, you teach is it you and your co-author together, Dr. Worsham, who teach a class that's really aimed at helping doctors, prioritize or adapt to a high pressure workplace?
Well, Chris in particular would be very well poised. Chris is a longtime colleague of mine. He's a critical care doctor, health policy researcher at Harvard. So he sees the types of people for whom these sorts of decisions are probably the most relevant. I teach an undergraduate course where we talk about some of these things, but to get to your point, and I think Chris would probably feel this more even than me, given the types of people he sees in the throes of an acute critical illness, is we always want to do something. It's not comfortable to sit back and let a disease evolve. And most of the time, the right thing to do is to actually do something. But I think over time, over the last 10 years or so, I think there has been a movement to try to understand where are those areas where we might want to pull back, be a little bit more cautious, recognizing that everything that we do entails some sort of risk.
There's some aspect of this that you note in your book indicates that we might be flying blind, because doctors are often the last people to learn what actually happens after their patient leaves the hospital. They don't learn that 9 of the last 10 people they did that procedure to actually had a problem with it, or actually weren't happy about it a month later or 2 months later, because they've moved on with their lives and they haven't gotten back to you. That this seems like a problem that's built into the system that ought to be addressed.
Yeah, that's a huge problem. I think in many industries, you have the ability to get good feedback on the outcomes of what you do. And it's certainly the case that we do see instances where we get feedback. Again, in Chris's case, he's a critical care doctor. If he titrates a medication one way, he sees the blood pressure going up or down, and whether or not it's working. That's very useful real-time feedback. It allows for improvement and in a sort of rapid cycle way. But what happens if you are an emergency room doctor and you discharge a patient home because you think that they have a condition that is unlikely to be life-threatening? My colleague Ziad Obermeyer, who's at Berkeley, and I and others did some work where we look at this, and it 1 out of every several hundred people above the age of 65 who were sent home from the emergency room pass away. And that means there's a diagnostic error that occurs. How often are emergency doctors then given feedback of that? Very uncommonly. And so it makes it hard to learn from mistakes, which is really one of the things that we think is most important in medicine in terms of growth.
This is fascinating. doctors are humans, right? Humans make mistakes, but we try, and you are trying in your work to find ways to mitigate against potential mistakes by looking at the decisions they make and seeing if there's a way to correct in a macro way. A little more terminology here. You have studied availability bias as it applies to doctor errors and medical shortcuts that they might make. Can you tell us what availability bias is?
Sure, it's this. I'll give it in a medical context. So, imagine you are a doctor and someone comes to your clinic, or you see a person in the emergency department, and they have a clot in their lungs that we call a pulmonary embolism. That diagnosis is now sort of mentally available to you. It's just sitting in your mind. And it might be the case that the next patient that you see, either the next day or the next hour or the next week, who comes in with a similar set of symptoms, you might sort of have that in your mind, say, oh, I wonder if this is a pulmonary embolism. And you might diagnose it or try to diagnose it as such. And that might normally be okay because pattern recognition is really important. If that previous instance, that previous diagnosis sort of emblazons in your mind this pattern that you need to keep in mind anytime you see a person with shortness of breath and a fast heart rate, that can be a good thing. And we wouldn't call that a bias in some respect. We'd say I'd call that availability a good thing, for lack of better words, right? But we call it availability bias because it can also lead to a misdirection. You sort of think about this diagnosis because it's mentally available to you, happened to you recently, and it sends you down the wrong path. So there's all of these ways in which we I'll say the following, Bob, is that when people study things like the availability bias and other biases that cognitive psychologists study, it's sometimes striking to me that we see these in medicine, again, because the stakes are so high, and yet we do see it. So these are things that are hardwired into our brains.
There's a close cousin of availability bias, or maybe it's a variety of it, that in the book is called the win, stay, lose, shift bias. That to me is fascinating. It has to do and has a direct bearing on decisions doctors make for treatment. Sometimes you have data showing a big difference. What is the win, stay, lose, shift bias?
It's a similar sort of bias, and I'd say it's probably quite similar. When something goes well, you stick with it. When something doesn't go well, you don't stick with it. And again, that can be good if the reason why something went well is because of something that you learned and something you did right, and the reason something went poorly is because something that you know you did wrong. But sometimes things are random, and things that are intended to go right and that most of the time should have gone right actually go wrong. And if that leads you to shift gear, that can be a problem. Again, I think of this almost as misdirection, right? There is this randomness that operates in our lives as people who care for patients, and it can misdirect us in different ways. And that's sort of another example of that.
And it just feels like a human thing. I believe in the book you talk about, a doctor who just performed a C-section and it perhaps, didn't go so great with, there were issues, might be less, would shift, and they would be less inclined to perform a C-section on the next person. And you have data showing like a real difference, not just, now and then I won't do it because it went bad, but it just seems to happen a lot. And then vice versa. If it went great, then they might be more inclined to do it the next time.
Yeah. And I mean, this happens all the time. I was thinking the other day, actually, this is not in the book, but it's a related concept as a study idea. Imagine you were to study oncologists and you were to look at their patients and observe instances in which a person who has cancer does particularly well. They live longer than the oncologist would have expected receiving a therapy. There's two things you could infer from that. One is that, well, there's something about this person that led them to live longer than I would have expected. And that is sort of something I can't predict. I can't do anything about it. I can't replicate that in some way for somebody else. Or you think to yourself, wow, that medication that they're on, that's what made them live longer. And you might then see oncologists use that medication more often on other people. Now, if that medication is what helped that first person live longer than you would have expected, and now you use it in other people who it's appropriate for, that's a good thing. You'll see good outcomes result. But if the medication isn't what helped that person live longer, but your mind attributes their success to that medication and you use it in other places where it's not as appropriate, then people might do worse. So this is an area where I think we'll learn more and more about as we get more and more data on what works and doesn't work. But right now it's sort of native and ripe for these sorts of issues.
Mhm. Tell us what happens to doctors on their birthdays.
Well, they celebrate. I mean, I don't.
There's something stunning in your book about it.
Something surprising. So a colleague of mine, Yusuke Sugawa, who was a student of mine at Harvard and now is at UCLA, really interesting and clever guy. He approached me with this idea a few years ago, which we ended up doing together, and I wrote about it in the book with Chris, which is what happens to patients, when surgeons operate on their birthdays. Now you think, why would you even think about that? And I think what Yusuke would say is he was probably interested in this idea of distraction. We talked about the Joint Commission, these regulatory inspections, these surprise visits, as being a setting where we study the effect of more focus or taking away that lack of attention. Here it's the opposite, right? On a birthday, you might imagine that a surgeon who's operating could be a little bit distracted. Now, why might they be distracted? Maybe their phone is going off. That when you send happy birthday on the iPhone, there's these graphics that happen, and there's noises. Maybe the doctor and the nurses and the scrub techs in the operating room are talking about what he or she has planned. Maybe they skip out of the hospital a little bit early. Whatever it might be. Maybe they're distracted because they're turning 50 or 60 or 70, whatever it might be. It's distracting.
The balloons in the operating room. The balloons in the operating room.
Exactly. It's distracting. And you can see very clearly if you look at patients who undergo surgery on the day of their surgeon's birthday, the mortality rate for those patients, the operative mortality, is higher than on any of the surrounding days when the surgeon might operate. And to me, again, it speaks to an interesting way to be able to study the effect of distraction. It's hard to study. You can't just survey surgeons and say, all right, you had a bad outcome in that surgery. Were you distracted? Yes, I was distracted. That's not a reliable way to assess the effect of distraction on some outcome. The reliable way to do it is to randomize surgeons to more or less distraction, but that would be unethical. But you can imagine that there are other ways that you could do that, and this is one way. By the way, Bob, I mentioned, I think in one of the footnotes of the book, that we looked at what happens to surgeons, surgical outcomes the day after major stock market crashes. And I was thinking to myself, all right, a surgeon's portfolio just falls by 10, 20%. Are they more distracted? And does that lead to worse outcomes? We didn't find any evidence of that. So maybe they care more about their birthday. I don't know.
There are other findings that are also slightly counterintuitive, but I think that it could be news you could use for the people watching today. You have in the book a comparison of old doctors versus young doctors that's surprising.
Yeah. So when I walk I'm curious, when you walk into a room and you see the doctor in front of you, would you be Bob, would you be a little bit apprehensive if they were in their 30s, low 30s? Would you be, I'm not sure.
Totally. The guy who did my colonoscopies looks like a baby. It's scary.
Exactly. That's what happens when we get old. Everybody's looking younger and younger. But yeah, so that's the idea behind our study. Is we were wondering, all right, if a person doesn't have much experience as a doctor because they haven't been around the block, they haven't seen lots and lots of patients with lots of different conditions, might their outcomes be worse? And when we look at the data, we look at doctors who provide hospital care, and that's an important group of doctors to look at because if you otherwise say, let's look at patients who see older doctors or younger doctors, there is this bias that emerges because if you think that older doctors are wiser and will provide better care, which types of patients will select those doctors? Typically patients who've got more going on, who might be a little bit sicker. And then if you just look at an analysis of outcomes of patients of older and younger doctors, you'd see that the older doctors have worse quote unquote outcomes. But it's not because they did anything differently. It's just because the patients that they were treating were more medically complex, were more likely to have negative outcomes or bad outcomes. And so we get around that by saying, well, in the hospital, you don't get to pick typically who your doctor is. You go on Monday, you get Bob Kolker. You get to come on Tuesday, you get Bapu. You go on Wednesday, you get Lonnie, etc. And it's totally random. And so the doctor who you see in the hospital, their age might be random with respect to why you're going there in the first place.
Mhm.
And what you see is that younger doctors actually have better outcomes. The mortality rate for their patients, and these are just general medical problems like pneumonia or heart failure or infections, younger doctors have lower mortality than older doctors. And I think the reason why is because even though older doctors tend to have more experience, they've seen more things, younger doctors are sort of fresh out of training. They're closest to like up-to-date medical knowledge, treatment guidelines. So that's probably what explains it. The important caveat, though, is that older doctors who remain clinically very busy, they don't seem to face that penalty. They do just as well as younger doctors. But it's older doctors who don't see as many patients where you start to see concerns about increased mortality.
So we see that age and experience matter less than how busy they are in the present moment, what their workload is like in the present moment, which is
Yes.
fascinating to me. What about men versus women doctors?
This was a study that we did years ago in 2015, 2016. That's in the book. We look at we look at hospital-based doctors because there's this randomization that we can leverage. And what we see is that female doctors have lower mortality rates for their patients than male doctors. And the reason that we were in part interested in this question is because there's, as in many other occupations and industries, women get paid less than men. They get promoted less quickly than men. We've done a lot of work in medicine that shows that even for very similar work. So if you look at women and men who have the same years of experience, went to the same quality, quote unquote, medical school, same number of scientific publications, all of these things, we still see that women get paid less and are promoted less. And so we're interested in what was going on with the clinical care as well. And what I think explains this finding is that there's probably some general differences between how men and women as doctors may approach medical care and medical problems. It could be things related to the time that's spent at the bedside. There's been other studies since ours that show that female doctors spend more time at the bedside. There's evidence outside of medicine that in finance, for example, that when it comes to complex decisions with uncertainty, that men may tend to sort of anchor in on a decision or a diagnosis, if you will, a little bit more quickly than women. And as I sort of alluded to earlier, when you see a complex medical problem, you need to have a broad differential in your mind. You don't want to anchor in too quickly on a diagnosis because you might be wrong. So there's substantive differences in mortality rates for patients who are treated by men versus women doctors.
One more slightly related to this before moving on to heavier stuff. Does it matter in the end which medical school your doctor goes to?
It doesn't matter as much as you might think. I'll say that. So, when I look for a doctor, I'm probably biased. I'm looking at where they trained, and my mom, she's a retired physician, and she trained in India in a very low resource stake setting, and so she had to prioritize a lot of different types of skills than doctors who train here in modern days would prioritize. But the short of it is that if you look at doctors who trained in foreign medical schools, they tend to have better outcomes than doctors who trained in domestic medical schools, which is a finding that sometimes surprises people. And the other thing is that if you look at doctors who trained at very quote unquote prestigious, highly ranked medical schools in the US versus lower ranked medical schools, they don't tend to have much better outcomes. In fact, they're pretty similar when it comes to things like hospital mortality. So where they train may not matter as much as you might have thought, or I might have thought.
Interesting and useful, for sure. Just a quick note to the audience. I'm not giving away the store here. There's tons of stuff like this in the book, and we would need more than an hour to get through to get through it all. This is just the tip of the iceberg. And then material later on in the book actually has some surprising material about more weightier matters. And of course, one of the biggest natural experiments out there over the past few years is the COVID-19 pandemic. You have lots of information about how things happened within various populations, but one thing that interested you was whether politics had a bearing on how a person fared during the pandemic.
Yeah.
So looked at politics of doctors too in a different setting, just to see whether vaccination was something that a right-wing doctor would be less inclined or more inclined to do than a right-wing doctor. But then you looked at death rates of the entire population and saw that some key information about what happened once the vaccine came along. Can you tell us about that?
Yeah. So maybe I'll just say two of the findings I think were sort of most interesting to me, at least. One is COVID related and one is not. The COVID, we had a study a couple years ago, was motivated by our daughter who was turning, I think, 6 at the time. And my wife and I were struggling with whether or not to have a in-person birthday or a Zoom birthday. With the in-person birthday was going to be with people that we knew very well. We sort of trusted them. We thought we were all going to be safe. We ended up doing a Zoom birthday, but which was quite nice, by the way. But it made me think of birthdays as sort of an interesting experiment, because people had been wondering early in the pandemic, what were the things that led to disease spread? Was it these large super spreader events? Was it getting together with people that you do not know, or like at a bar or a restaurant, or maybe small social gatherings matter? The challenge is that it's impossible to study the effect of small social gatherings on COVID spread, because you would need large amounts of data on who is gathering, when they are gathering, do they get COVID-19, and what are the things they might be doing differently. The people who gathered a lot early in the pandemic might have been masking less, traveling more, all sorts of other things. And that's where the birthdays came in. We looked at large data from insurance companies where we knew the birthdays of individuals. And what we showed is that when a household in a given city had a birthday, a member had a birthday, not a birthday party, just someone has a birthday, that household was about 20 to 30% more likely to have a COVID-19 diagnosis in the 2 weeks following an otherwise similar birthday that in that week, in that town, nobody in that household had a birthday. So it's totally random. And the interesting thing was that this birthday effect was in large part driven by kids' birthdays, because it's hard not to celebrate your kid's birthday. But the other thing, and this talks about the politics of it, is the birthday effect was the same in highly blue areas of the country and highly red areas of the country, which suggested to me that when it comes to something that you value a lot, people didn't make that many different decisions, right? We survey people, we see what we see on social media. It's different than what people might do when they care about something.
It was such a bad news period, and so much dispiriting disagreement over how best to handle the pandemic. And yet you highlight something that really actually never, for me at least, never got through the noise and made it to me until I saw it in your book, which is that among adults, 90% of us had at least one vaccination for COVID, which is, 90% is enormous. It's enormous. You've called or you've quoted people characterizing our treatment, our reaction to the pandemic, a successful failure. Can you explain that for us?
Yeah. The way I think about the pandemic, I mean, the ways in which people are different have been heavily magnified. There's no doubt about that. But I think what we fail to understand is that everybody paid a price. It doesn't matter who you were or how you were living your life. Everybody paid a price. And there is this, silver lining, if you will. I mean, most Americans don't agree on 90% of anything. In fact, in the book, I think we make a joke about getting vaccinated was more American than apple pie. If you look at what percentage of people in surveys like apple pie, the only thing that people might agree with more is about the quality of the movie I think it's Julie or Julia, the one with Ben Affleck and Jennifer Lopez. Geely.
Big
Geely.
deal, yeah.
Yeah, Geely's got a little bit lower ranking on Rotten Tomatoes. So COVID vaccine, Geely, I don't know. But you know, the point is that everybody paid a price, and sometimes that point is lost.
Thank you. Oh, I see Lonnie's back. Hello.
Hi, Lonnie's back. We are at 7:57, so we got about 3 minutes left. Bob, I want to thank you for such a informed and thoughtful and prepared interview for Bapu. I'm sure he appreciates that as well. You brought out a lot of great pieces in the book, and you're 100% correct that there is so much more in the book. We've been popping in chat. Anybody who makes a donation to FAN during this program, we're going to send you a link to After Hours. We're going to continue this conversation in a Zoom meeting that's going to start at 8:05 Central. It's going to run until 9 o'clock Central. Both Bapu and Bob will be there. Come join us, ask your own questions. Bapu, I'm going to give you a quick heads up right now. I'm going to want to know, like, okay, so the average person, if you're thinking, what kind of doctor do I want? You gave us all these various things: old, young, male, female, primo med school, not primo med school. Don't go if it's their birthday. I want a cheat sheet. Like, okay, I need to go get, some surgical procedure. What don't I want? What do I want? So we'll talk about a little bit about that in After Hours. There's a question in particular Jerry asked in the Q&A that I'd love to get an answer from. He says, thanks for the fascinating conversation. He says, are there any examples in your book that feature the context of mental health care in particular, which would be of high interest to folks here?
Yeah, it's an enormously important issue. We don't touch really on mental health care, which I think is actually, to be honest, is an important omission of the book. We talk a little bit about issues around psychiatry and psychiatric diagnoses. For example, we talk about this relationship between birth month and ADHD, whereby kids who are born in August in states that have a September 1 cutoff for school entry are more likely to be diagnosed with ADHD than kids who are born in September. And the reason why is because they're just young for their grade. They behave less maturely than their older peers. And there is a link actually to the mental health question, because in other studies, not in our own, but kids who are young for their grade are more likely to struggle with suicidal ideation and depression and anxiety. So there are little kind of nuggets of things in our book that talk about these issues, but that's an omission, I think, in my view.
Well, thank you. I appreciate that. So we're coming up on 8 o'clock. I hope everyone comes. Thanks for those who have already donated. We appreciate the donations. I hope more will come to After Hours. We're going to have a great conversation. Bapu, thank you so much for your service to FAN and our community. We very much appreciated learning from you. And Bob, we'll see you in a few more minutes. We love that you're part of the FAN family. Thank you so much for your help tonight. Really appreciate it. Everyone, hope to see you at more Zooms and in-person events going forward. Really busy year. I think we have 9 programs in October, which is kind of crazy. So anyway, have a good night, everyone.